Доброго дня, шановні колеги. Ви
Good
підключаєтеся
afternoon,
до
dear
вебінару
colleagues. You're
щодо
joining the
здоров'я
webinar
рослин,
of the Ukrainian
бета-лактам і
public health
антибіотики. Поки що
sector,
ми почекаємо, доки
Beta-lactam
учасники будуть
antibiotics.
підключатися до
Let's wait until
зустрічі.
all the
Буквально
participants
через
join the
8
meeting,
хвилин
and
ми
we
почнемо
are
наш вебінар.
starting within a
А
few
поки що ви
minutes.
можете
Meanwhile,
налаштувати ваш переклад
you can just
і підготуватися
tune
до
up
цікавого
your
вебінару.
interpretation and get ready for the interesting webinar. Thank you.
Доброго дня, шановні колеги. Ще раз я вибачаюсь, певні
Hello, dear
технічні
colleagues, once
проблеми
again.
з мого
Sorry for
боку.
some technical issues from my side.
Зараз ми будемо починати вебінар.
Now we're going to start the webinar.
Отож, ще раз всіх вітаю на
And
вебінарі.
let me welcome you again at
Нагадую,
our
що це
webinar. Let
продовження
me
циклу
remind you that
наших
this is the
вебінарів,
continuation
які ми
of
вже
the series of the webinars we've been having since 2023, and we're going to continue them. So I'm inviting you to take an active part in the future activities. Today's webinar is dedicated to the lecture on beta-lactam antibiotics, mechanisms of action, range of action, pharmacokinetics, pharmacodynamics, and clinical indications. Today's speaker is the experienced expert, one of the best experts, Professor Maria Santini. She's from the University Hospital on Infectious Diseases, named after Fran Mihaljevic from Zagreb, Croatia. So she will present you the lecture. But before she starts, I would like also to express gratitude to our partners and colleagues who are helping to fund and implement these activities, namely US CDC and the ICAP of Columbia University, who we are delivering these webinars together with. And actually, at today's webinar, we have the simultaneous interpretation. To use this feature, please find the globe-shaped button, select Ukrainian channel, to be able to listen to the webinar in Ukrainian, or you can listen to it in English. As usual, we will record this lecture, and you can then rewatch it at the YouTube channel of the UPHC. Further announcements will be provided at the Facebook page of the UPHC, so please subscribe and follow our future announcements. And with no further delay, let me give the floor to Professor Santini. Over to you, Maria.
Hello, everyone. I want to express my gratitude for inviting me for this presentation. And I want to send to all of you my support and my warmest regards. And I'm very happy to be with you here today. And I hope that this lecture will be helpful, I would say, for all of us. So today we will talk about beta-lactam antibiotics. As you can see on this first slide, these antibiotics actually have a great activity thanks to this this purple, as I actually depicted it, this purple square, or speaking in chemical terms, actually it is a ring of molecules, beta-lactam ring. And we will see what these antibiotics can do with this. So as you can move on to the next slide. So as you have already heard, I'm an associate professor at the University of Zagreb Medical School, and I'm an infectious diseases physician at the University Hospital for Infectious Diseases in Zagreb, Croatia. And this is the list of companies that I was collaborating with in the last years. You can proceed. So we will talk about what will we talk about today. So we will talk about what are beta-lactam antibiotics, what is their mechanism of action, how does beta-lactam resistance occur. We will go very briefly through the pharmacokinetics and pharmacodynamics of these antibiotics, classification, clinical use. Then we will go through new beta-lactam antibiotics, the problems in clinical use, and why are beta-lactam antibiotics so vital in the treatment of infectious diseases. You can go on. Okay, so you can see here beta-lactam antibiotics. Actually, we have 4 main groups of beta-lactam antibiotics. All of them have this magic beta-lactam ring, and next to it, they have different side chains, or they have attached different rings. And depending on these side chains and rings, it changes their pharmacodynamics and pharmacokinetics. So we have 4 main groups of beta-lactam antibiotics: penicillins, cephalosporins, carbapenems, and monobactams. What is the mechanism of action? You can proceed to the next slide. Okay, here on the left-hand side, you can see the cell wall of gram-positive and gram-negative bacteria. What you can see on the left side, it is that gram-positive bacteria have a very thick peptidoglycan layer, while gram-negative bacteria, they have a thick one, not so thick one. And beta-lactam antibiotics, they bind by their beta-lactam ring to proteins that are situated in the peptidoglycan layer. These proteins are called penicillin binding proteins, and actually they have the activity of the enzymes transpeptidases. When they bind to these penicillin binding proteins, actually they stop their action. They cannot produce any more peptidoglycan. And in that case, the bacterial cell wall actually stops in evolving and the cell dies. It is not actually known what is the mechanism of death of the bacterial cell, but most of the beta-lactam antibiotics actually have bactericidal activity. You can proceed to the next slide. So here you can see the four main mechanisms of the resistance. The first mechanism is reduced permeability of the outer membrane. The second one is degradation by beta-lactamases. As we know today, we have more than 1,000 beta-lactamases, and usually we say that for every good beta-lactam, we have a good beta-lactamase, or more than one. Then the next mechanism of resistance is the changing of these penicillin binding proteins that I showed on the previous slide, the green one, posts where these molecules bind. And this is particularly important for gram-positive bacteria and active efflux. What I would like to stress is degradation by beta-lactamases, because it is today the most important mechanism of resistance of the multi-drug resistant gram-negative bacteria, because we have in Croatia huge problem with the resistant gram-negative bacteria, and changing of PBPs, which is particularly important in gram-positive bacteria in Staph aureus and streptopneumonia. You can proceed to the next slide. So I would say that actually the most important mechanism is production of beta-lactamases. And actually these enzymes are destroying this magic ring of beta-lactams. And when you have this situation, actually the only thing that you can do is add the inhibitor of beta-lactamases, so not to have this situation in which the ring is destroyed. You can proceed to the next. Speaking about beta-lactamase inhibitors, which we are adding to the beta-lactams, actually we have two groups of these drugs. Some of them, these which you can see on the left side of the slide, these are beta-lactams themselves. So these are beta-lactamase inhibitors, which are beta-lactams. And we call them suicidal inhibitors because once they bind, actually they lose their activity. And it is so, and there is one exception, it is sulbactam, which has its own activity, which is especially important in MDR Acinetobacter today, because in Croatia we have a huge problem with Acinetobacter too. So clavulanic acid, tazobactam, actually are beta-lactamase inhibitor, which are beta-lactams themselves. On the right-hand side, you can see beta-lactamase inhibitors, which are non-beta-lactamase, which are not beta-lactams. And actually, these are new inhibitors, which are used in new combinations of beta-lactams and beta-lactamase inhibitors. These are avibactam, vaborbactam, and relebactam. These inhibitors, actually, they bind to the beta-lactamase and restore the main antibiotics activity, and they do not broaden the spectrum of the main antibiotics. We can go on. Okay. Here we will say something about basics of pharmacokinetics and pharmacodynamics, because beta-lactam antibiotics are a group of antibiotics in which their activity is time dependent. It means that we have to have the concentration above the minimal inhibitor concentration for as long time as we can get. So you can proceed to the next one. So you can see here a graph of the curves. So the green curve is the pharmacokinetic curve of the intermittent infusion. Here you can see that concentration of drug drops below the minimal inhibitory concentration. If you are giving this drug continuously, which is shown by the red curve, in this case, you will have the concentration which is above minimal inhibitory concentration. But sometimes giving continuously drugs, it is not convenient, and sometimes you have the problems with stability of drug. So what we are trying to do today is this blue line. So usually we give the first loading dose of antibiotic during the 30 minutes, and then after we try to give it in prolonged infusions, usually during 3 hours. In that case, we are achieving concentration above the minimal inhibitory concentration for a proper time, and the dose and the concentration above minimal inhibitor concentration is satisfactory. So for beta-lactam antibiotics, usually we have to give them multiple times a day in prolonged infusions, usually over 3 hours. Not for all of them, but especially for the new antibiotics, which are for the treatment of multi-drug resistant gram-negatives, usually we have to do it this way. So the first, you can proceed to the next slide. So the first group of antibiotics, beta-lactams, these are natural penicillins. In this group, we have benzyl penicillin and its long-acting parenteral forms for intramuscular use, and phenoxymethyl penicillin, which is usually given oral. You can proceed to the next. Regarding the natural penicillins, their main indications are infections that are caused by group A streptococcus, by gas, at any site, including the toxic shock syndrome and neurosyphilis. If you have the shortage of these antibiotics, then you should reserve these antibiotics for these two indications. The other indications are the sepsis or CNS infections, central nervous system infections, which are caused or by a proven susceptible bacterium as strep pneumoniae, Neisseria meningitidis, Streptococcus agalactiae, and the others. You can see this in the slide, actinomycosis and leptospirosis. And to put it in a nutshell, so natural penicillins, they're usually given as targeted therapy and empirically only in sore throat and erysipelas. You can move to the next slide. So anti-staphylococcal penicillins. Today, in Croatia, we have only one available. It is flucloxacillin, which you can give orally or intravenously. You can proceed to the next one. So the clinical uses of flucloxacillin usually are skin and soft tissue infections, bone and joint infections, respiratory tract infections, endocarditis, and other infections. Flucloxacillin usually is the first choice for methicillin-susceptible Staph aureus, sepsis, and endocarditis. And it is still so, although this year at ESCMID in Vienna, actually new studies were demonstrated in which probably the first generation cephalosporins could have better results than flucloxacillin, but still flucloxacillin is the first choice for methicillin susceptible Staph aureus. You can go to the next slide. Aminopenicillins. In this group, we have ampicillin, which is given intravenously, amoxicillin, which is given orally, and amoxicillin with clavulanic acid, which could be given orally and intravenously. I have to say that as far as I know, in US, there is no intravenous form of amoxicillin clavulanic acid, only the oral one. In Europe, we have amoxicillin clavulanic acid in oral, intravenous, and intravenous form. So you can proceed to the next slide. So ampicillin is intravenous form of drug. It is usually used for bloodstream infections, which are caused by Enterococcus, then for infections that are caused by Listeria monocytogenes, but usually in combination with other drugs, for endocarditis, which are caused by Enterococcus, Hatzek group, Viridan streptococci, and it is used for meningitis, which is caused by Listeria, Streptococcus agalactiae, Enterococcus haemophilus, Neisseria meningitidis, Streptococcus pneumoniae, and uncomplicated UTIs. To keep it short, ampicillin is usually given mostly targetedly and empirically if there is suspicion of Listeria monocytogenes meningitis. So if you have a patient who is over 50 years old or is immunocompromised and has signs of central nervous system infection, then ampicillin should be a part of combination for treatment of the central nervous system because there is possibility of Listeria. So usually, to conclude, ampicillin is usually used for infections which are caused by Enterococci and Streptococci and Listeria. Amoxicillin orally usually is used for acute otitis media, or at least we would like it to be used for this, because acute otitis media is the indication number one for oral amoxicillin, because it is the way to reduce to get to the reduced susceptibility of strep pneumonia to ampicillin. And it is used for community-acquired. Okay, please proceed to the next slide. Okay, so amoxicillin orally is used for acute otitis media. It should be the first indication. In Croatia, we have problem because usually amoxicillin with clavulanic acid is very frequently administered for this indication, and it is not the number one indication. So for acute otitis media, amoxicillin should be used. Then the second indication is community-acquired pneumonia, rhinosinusitis, streptococcal pharyngitis, eradication of Helicobacter pylori, bronchiectasis, skin infections, and targeted therapy of UTIs. So amoxicillin is usually mostly used empirically, and targeted use is for uncomplicated UTIs, usually for asymptomatic bacteriuria in pregnancy and acute cystitis. You can go to the next slide. So amoxicillin with clavulanic acid, the main indication is pneumonia in patients who are over 65. And acute rhinosinusitis, COPD, and acute otitis media, it is not the first choice. The other indications are bronchiectasis, exacerbation, urinary tract infections, pyelonephritis, and uncomplicated cystitis. So in Croatia, at least, the use of amoxicillin clavulanic acid is very commonly unwarranted for empiric choice and especially for upper respiratory tract infections. So I would say that amoxicillin clavulanic acid should be used in lower respiratory tract infections in beta-lactamase producing bacteria if they are suspected. You can go to the next slide. Okay, cephalosporins. You can go to the next slide. Okay, here is a story of cephalosporins. Actually, they have been invented in Italy by a medical microbiologist. His name was Giuseppe Brozzu, and he was living on the island of Sardinia. And he observed there, actually, he was treating patients with typhoid fever, and he was involved in eradication of typhoid fever. And then he observed that none of the people who were swimming in the bay, where all the sewage water from the city was coming, and that none of them got typhoid fever. So he concluded that there should be something in the seawater that actually is preventing people from getting typhoid fever. Then he gets to the notion that there is a kind of fungus in this seawater. It was called cephalosporium. And actually, he got to the compound which was called mycetin, which was later developed in UK to get the first cephalosporins, which are in use since 1968. So usually people, they know about Alexander Fleming and his invention of penicillin, but very few people know about this gentleman who invented cephalosporins, which are today a very important part of our treatment and very important member of the beta-lactam family. So when you are thinking about cephalosporins, you should note that actually they came from this observation of the epidemic of typhoid fever in Italy. You can go to the next slide. So today we have five generations of cephalosporins. First generation, they have good activity for gram-positive bacteria. Second generation, they have good activity for gram-positives and gram-negatives. Third generation still has good activity for gram-positives, but broader activity from gram-negatives. Fourth generation, they have better activity for gram-negatives, especially for Pseudomonas. And the fifth generation actually has excellent activity for gram-positives again, especially for MRSA. In cephalosporin family of antibiotics, we have cephalosporins with beta-lactamase inhibitors. Actually, these are new drugs. I will talk about them later. These are ceftazidime avibactam and ceftolozane avibactam, and there is another new antibiotics which is called cefiderocol. And these antibiotics actually are used in treatment of MDR gram-negative bacteria. You can go to the next slide. Okay, the first generation cephalosporins. Here we have cephazolin, which is used intravenously, and cephalexin, which is used orally. You can go to the next slide. So cefazolin is usually used as surgical prophylaxis, and it should be the first drug which is used for surgical prophylaxis. It is used in infections of the skin and subcutaneous tissues. It is used for toxic shock syndrome, for bloodstream infections, for endocarditis, for community-acquired mild to moderate intra-abdominal infections, osteomyelitis, prevention in open fractures, artificial joint infections, septic arthritis, pneumonia, prostatitis, and complicated UTIs. So, but what I would like to stress that cefazolin is usually used for surgical prophylaxis for infections with suspected or proven methicillin susceptible Staph aureus, endocarditis, osteomyelitis, and it covers methicillin susceptible Staph aureus and group A streptococcus. So you can go to the next slide. Cefalexin, it is oral antibiotic. It is usually used for infections of the skin and subcutaneous tissue. It is used for group A streptococcal pharyngitis, not as the first choice. It is used for lactation mastitis and UTIs. So I would say shortly that cefalexin is used for mild infections of the skin and subcutaneous tissue. You can go to the next slide. The second generation of cephalosporins, here we have cefuroxime, which is used intravenously, and cefuroxime acetyl, which is used orally. You can go to the next slide. Okay, the main indications are community-acquired pneumonia, COPD exacerbation, Lyme disease, but without central nervous system involvement, group A streptococcus pharyngitis, but not as the first choice, surgical prophylaxis in head and neck surgery in combination with metronidazole and UTIs. So I would say that cefuroxime is usually used for infections of the upper respiratory system for sinusitis, acute otitis media. Okay, you can go to the next slide. Okay, the third generation cephalosporins. Here we have ceftriaxone, which can be given intravenously and muscularly, cefotaxime, cefixime, cefpodoxime, and ceftazidime. You can go to the next slide. So ceftriaxone is usually given intravenously, and here is its twin antibiotic. It is called cefotaxime. These drugs are actually twins. They have the same spectrum, but they don't have the same pharmacokinetics. Ceftriaxone should not be given to neonates to the newborns because it has competition on the binding site of albumins with bilirubin. So in newborns, it can make worse the hyperbilirubinemia. So there are many indications for ceftriaxone, but I would say that the main one is bacterial meningitis, which could be caused for strep pneumoniae, Neisseria meningitidis, Haemophilus influenzae. I would say especially for strep pneumoniae. So usually it is included in empirical treatment of bacterial meningitis. Then for bloodstream infections, community-acquired pneumonia with no risk for Pseudomonas. Then community-acquired intracranial or spinal abscess, infections of the skin and subcutaneous tissue, complicated UTIs, and other indications. For both of these drugs, I would say that they penetrate well into the central nervous system. And actually, I would say that in many cases, ceftriaxone today is the first empirical treatment for those patients who are hospitalized or for those who are in intensive care unit. But I have to say that very often ceftriaxone actually is misused, and it should be because it is given only once a day. It has very good pharmacokinetics, so sometimes there is unwarranted use of ceftriaxone. You can go to the next slide. Ceftazidime is the member of the third generation cephalosporins family. The main indications are bloodstream infections, healthcare-associated abdominal infection, intracranial and intraspinal abscess, bacterial meningitis, and febrile neutropenia. I would say that these are the main indications. And I would say that ceftazidime is a third-generation cephalosporin, but with better activity for Pseudomonas. You can go to the next slide. The fourth-generation cephalosporins. Here we have cefepime, which is given intravenously. You can go to the next slide. So the main indications are healthcare-associated intra-abdominal infections, intracranial and intraspinal abscesses, bacterial meningitis if there is possibility of Pseudomonas, and febrile neutropenia. So it is cephalosporin with a good effect on Pseudomonas and good penetration into the central nervous system. So if you are suspecting Pseudomonas, then you can give cefepime. You can go to the next slide. The fifth generation cephalosporins, you can go to the next slide. Here we have ceftaroline, which is given intravenously. It has good activity for MRSA. The main indications for this actually new drug are infections of the skin and subcutaneous tissues and pneumonia, healthcare-associated pneumonia, not ventilator-associated pneumonia, and off-label indication is bloodstream infection. So it is the new member of cephalosporin group, the fifth generation cephalosporin with good activity against MRSA. You can go to the next slide. Here we have carbapenems. And main members of this group are imipenem, meropenem, and ertapenem, and all of them are given intravenously. You can go to the next slide. Imipenem. It is given intravenously, and the main indications are bloodstream infections, which are caused by MDR gram-negatives. But I have to say here that actually it is reserved for extended beta-lactam spectrum, ESBL, extended spectrum beta-lactamase producers. Then for endocarditis, which is caused by these bacteria, community acquired and healthcare-associated intra-abdominal infections. Then it is very interesting that it has activity for non-TB mycobacteria, and it could be used in pneumonia, skin and soft tissue infections, and UTIs, complicated ones. So I would say that imipenem actually is reserved for nosocomial infections, especially those which are caused by extended spectrum beta-lactamase producers. It works on enterococci, unlike meropenem. It works on some non-TB mycobacteria and nocardia. It does not work on proteus and all proteaceae, and it has epileptogenic potential, and this is the reason why it is not given if central nervous system infection is suspected. You can go to the next slide. Meropenem is a similar drug, but some differences. It is also reserved for nosocomial infections. It has lower epileptogenic potential, and it is frequently used if you suspect central nervous system infection. It is very frequently misused in many hospitals because physicians actually are afraid that they are dealing with multi-drug resistant bacteria. And maybe if you have a very severe infection, it is not so wrong to go with meropenem, especially if you have high prevalence of ESBLs, but it is not wrong if you start with this and then after 24 or 48 hours, when you have the results of microbiology, if you de-escalate and go to the antibiotic of the more narrow spectrum. Okay, you can go to the next slide. Ertapenem. Ertapenem is a carbapenem too. Usually it is said that this first letter of the word ertapenem, E, is for exception, because there is one exception from the previously mentioned carbapenems, because Pseudomonas is intrinsically resistant to ertapenem, so ertapenem cannot do anything with Pseudomonas, but usually we say that ertapenem is a carbapenem that spares Pseudomonas, actually does not produce Pseudomonas resistance to carbapenems. So, and it is very convenient because it is given only once a day intravenously, and if you have outpatient clinic and the patients can come, for example, for complicated UTIs which are caused by ESBL, sometimes it is very convenient to give ertapenem only once a day. You can go to the next slide. Here is another group of beta-lactams. These are monobactams. Actually, we have only one member. It is called Astreonam. You can go to the next slide. Actually, Astreonam was a little bit forgotten drug until lately, when we came to the, actually, I would say, pandemic of the multi-drug resistant gram-negatives, which are producing metallo-beta-lactamases or MBLs. So for MBLs, actually today it is a solution. It can be used in bloodstream infections, intra-abdominal infections, pneumonia, skin and soft tissue infections, and UTIs. And a few months ago in Europe, a new combination of Astreonam with avibactam, so it is beta-lactam with beta-lactamase inhibitor. It is the first choice for MDRs, gram-negatives, which are producing MBLs, and for Stenotrophomonas maltophilia. So today this drug actually, which was invented some 30 years ago, is living its new life because it is used in these indications for multi-drug resistant MBL producing gram-negatives. You can go to the next slide. Now I will talk about new beta-lactam, beta-lactamase inhibitors, actually about drugs which were approved during the last 10 years. Here we have ceftazidime avibactam, ceftolozane tazobactam, imipenem relebactam, meropenem vaborbactam, Astreonam avibactam, and sulbactam durlobactam. Okay, you can go to the next slide. So, ceftazidime avibactam. The indications for its use are complicated intra-abdominal infections, complicated urinary tract infections, hospital-acquired bacterial pneumonia, and infections caused by carbapenem-resistant enterobacteria. It is not active against metallo-beta-lactamase producers. So I would say that ceftazidime avibactam today is the first choice for KPC or OXA48 producing carbapenem-resistant enterobacteria. Okay, you can go to the next slide. Ceftolozane tazobactam is approved for complicated intra-abdominal infections, complicated urinary tract infections, hospital-acquired and ventilator-associated bacterial pneumonia, and it is effective against MDR Pseudomonas. So I would say that the main indication for ceftolozane tazobactam is so it is the first choice for carbapenem-resistant Pseudomonas aeruginosa. You can go to the next slide. What are the clinical uses of imipenem relebactam? These are complicated urinary tract infections, complicated intra-abdominal infections, hospital-acquired bacterial pneumonia, and infections due to resistant organisms, especially due to carbapenem-resistant Pseudomonas aeruginosa. You can go to the next slide. Meropenem vaborbactam, it has similar indications. These are complicated urinary tract infections, complicated intra-abdominal infections, hospital-acquired and ventilator-associated bacterial pneumonia, and infections caused by carbapenem-resistant enterobacteria. So I would say that the infections caused by carbapenem-resistant enterobacteria are the main indication for meropenem vaborbactam. You can go to the next slide. And now we have this Astronom avibactam, which is approved for infections caused by MBL-producing organisms, for complicated urinary tract infections, for complicated intra-abdominal infections, hospital-acquired and ventilator-associated pneumonia, and bacteremia and other systemic infections. So MBL producers and Stenotrophomonas are the main indications for the use of Astronom avibactam. You can go to the next slide. And here we have a new drug, which was approved last year in US, and it was immediately put into the IDSA guidelines for treatment of gram-negative, MDR gram-negative infections. The indications for its use are infections which are caused by carbapenem-resistant Acinetobacter baumannii, hospital-acquired bacterial pneumonia, alternatives to colistin-based regimens, and potential uses in bloodstream infections and bacteremia. So I would say that today sulbactam, durlobactam, is in US is the first choice for MDR Acinetobacter baumannii. We can go to the next slide. Here we have a new cephalosporin, cefiderocol. It is siderophoric cephalosporin, which uses bacterial transport for iron for entering the bacterial cell. And the main indications are complicated urinary tract infections, hospital-acquired pneumonia, infections caused by carbapenem-resistant gram-negative bacteria, bacteremia, and it is salvage therapy in extensively drug-resistant infections. You have to know about this caution that higher all-cause mortality was observed in some trials involving Acinetobacter baumannii, so it is not advised to give this drug for Acinetobacter in monotherapy. Today, I would say that the main indication for cefiderocol actually is MDR pseudomonas. You can go to the next slide. Here, actually, you have the summary of these new antibiotics or new beta-lactams in combination with beta-lactamase inhibitors. And we can go to the next slide. Okay. And here you have this, I would say, streetlight diagram in which you can see which microorganisms are the most problematic these days, because actually we don't have enough solutions for this. You can see that the most of the red fields are associated with carbapenem-resistant Acinetobacter, Pseudomonas, and MBL producers, while for the others we have some solutions, but actually I would say that for Acinetobacter in Europe we still don't have very good solution for treating severe infections which are caused by Acinetobacter. We can go to the next slide. What are the problems in clinical use of beta-lactams? We have to say that sometimes our patients are reporting allergy to penicillin, but we all know that these are not true allergies. And this is one of the mechanisms of antimicrobial stewardship to delabel these false allergic reactions to beta-lactams, because if we exclude beta-lactams, then we are usually going to more toxic drugs, the drugs with more side effects. Beta-lactams, they have some side effects, but usually they are not so serious like in other antibiotic groups. For some of them, renal impairment or hepatic impairment could be a problem. You have to adjust those in these situations. And from time to time, in Croatia, we have problems with shortages of these antibiotics, with availability. Lately, we had a problem with availability of oral amoxicillin, Then from time to time, we have some problems with availability of piperacillin tazobactam. But these are just temporarily shortages. At this point, we have, I would say, more or less all of these drugs except sulbactam, durlobactam, which is not approved in Europe yet. We can go to the next slide. And I would say at the end that beta-lactams are vital for treatment of infections. They have some disadvantages, like bioavailability, because most of them, they have to be given intravenously. Antibiotic resistance develops in this group very quickly. I would say some of the most important members of this group. They have this time-dependent effect above MIC, so they need frequent administration in prolonged infusions over 3 hours. And here are these allergic reactions, which are real or false, and side effects. But they have very important advantages. They have bactericidal effect, but not always. For example, for Enterococcus, they are not bactericidal. They have very low toxicity, and they are really proven. We have very good proofs, very good evidence for most of them that they are effective in many clinical scenarios. You can go to the next slide. So I would like to thank all of you for your attention today and to send you again my best regards from Zagreb. Okay, thank you. I'm here for your questions.
Дуже дякую, професор Сантіні,
Thank you very much, Professor Santini, for this very interesting and very contentful presentation. That was very interesting, very informative. The beta-lactam antibiotics are the most consumed ones in Ukraine, I have to say. Thank you very much for mentioning the combined antibiotic forms. So, colleagues, if you have questions to ask, please use the chat box to ask those. Within our agenda, we will try to ask those questions to Professor Santini. And as the colleagues are preparing their questions, let me ask a question. Maybe that goes a bit beyond the topic of your presentation, but if possible, could you please speak a bit more about combination of beta-lactams with aminoglycosides as an option for combination like this? Is that possible, please?
Okay, you're asking about combining beta-lactams with aminoglycosides. Is it okay?
Так, все вірно.
Okay.
Absolutely, yes.
Okay, this combination is, I would say, useful in empiric therapy. But for the most of the infections, when you have the causative agent, you don't have to use combination. You can go and de-escalate to only one drug, and you can go to beta-lactams alone. Usually during the empiric therapy, I would say for the first 24 to 48 hours, you can combine beta-lactams with aminoglycosides. You have to know your epidemiology, the susceptibility of the pathogens that you are dealing with. And in that case, it is okay to go with beta-lactams and aminoglycosides. But after 24 or 48 hours, you can go to monotherapy. And that is something that I would advise.
Дуже дякую за відповідь.
Thank you very much, Professor, for this response. I absolutely support it. Whenever it is possible, you need to switch as quickly as possible to the targeted therapy following the results of your laboratory tests. And I see some questions popping up from my questions, but let me first make a quick remark. You mentioned the last resort, avibactam, plus
Астреонам та авібактам.
Astrianam
Такої
plus
лікарської
avibactam
форми фіксованої в Україні немає, та й в цілому її
form.
складно знайти
We don't have
будь-де,
it
але в
available
нас
in
є
Ukraine. You can
антимікробний
hardly
препарат
find it in
цефтазидім
Europe,
авібактам,
but we have
який
ceftazidime
доцільно,
avibactam,
якщо вже є така
which
потреба,
is
тому що цифтазидим це
reasonable
дуже
if you are in
коштовно,
a
комбінувати
complicated
з
situation
астреоном. Тобто
because it is pretty
цефтазидім
expensive.
авібактам
You can
плюс астреонам. Це актуально в
ceftazidime
контексті
avibactam
лікарських
plus
засобів, доступних на
Astrianam.
ринку
It could
України.
be relevant
Отож,
for Ukrainian
переходимо до
situation,
питання.
given the
Наступне
availability
питання
of these
було,
drugs in the Ukrainian
наскільки
market.
доцільним
Colleagues, that
ви
was just a
вважаєте
remark for you.
комбінування
The next
двох
question is, how
карбапенемів?
reasonable is it to combine two different carbapenems? How reasonable is that?
Okay, I know about this concept because usually the rationale for this was to give two carbapenems, and so the bacteria would get, I would say, with one carbapenem and forget the other one, which will actually do the job. Okay, but I don't think that this is good idea. Because by combining carbapenems, you're not getting anywhere. I would say that you will lose both of these. So I'm familiar with the concept, okay, but I would say I do not support this, okay, and I have never done this in my life.
Дуже дякую за відповідь.
Thank you very
Переходимо
much
до
for your
наступного
answer.
питання.
Let's switch to the
Наступне
next
питання
question.
дуже актуальне і
That is
дуже
very
доцільне.
topical, that is very
Окрема
relevant,
вдячність
and
людині, психологу.
I'm very
Це
thankful
запитують
to
про
the person who
перевагу
asks about
або
that.
які певні
So the question
переваги
is, what
цефатоксину
are
є
the
над
benefits of
цефтріаксоном. В контексті
cefotaxime
України це
over
доцільно, тому що ми
ceftriaxone?
намагаємося
In the Ukrainian
максимально
context, that looks
оптимізувати
very
використання
reasonable because we're
цефтріаксону.
trying to
Ним
optimize
часто
the use of
дуже сильно
ceftriaxone
зловживають.
as much as possible because it is
Які
often
переваги
misused,
цефатоксину
often
над
abused ways.
цефтріаксоном?
So what are the benefits of that?
Okay, we are talking about cefotaxime and ceftriaxone.
Так.
Yes.
It's the same. I don't think that you would benefit from this because these drugs have the same spectrum. Okay, so like using the twin drugs, and cefotaxime, you have to give it multiple times a day, and ceftriaxone only once a day, or if you are dealing with central nervous system, then 2 times a day. But actually, you will not go to the good antimicrobial stewardship side with this. Usually, you have to de-escalate from ceftriaxone and from cefotaxime to the antibiotics with more narrow spectrum, for example, to ampicillin or amoxicillin. That is something that I would like to see in Croatia because we are misusing ceftriaxone a lot because it is cheap, it is given once a day, it's good for gram positives, it's good for gram negatives, and I would like to see less use of ceftriaxone too, but not going to cefotaxime. I don't think that you will get anything with this.
Дуже дякую, пані професору, за відповідь.
Thank you very much, Professor, for your answer. I fully support this, that if possible, we need to seek de-escalation from cephalosporin's third generation to penicillins or to younger generation. And we understand that ceftriaxone as a reserve antibiotic in Ukraine, maybe for the variety's sake, we can replace it with a cetotoxin as an equal one. The next practical question is, can you tell us, Professor, are there any cross-allergic reactions when using penicillin and cephalosporin and cephalosporins with carbapenems, and how often does it happen in practice?
Okay, not so often. The cross-reaction from natural penicillins with cephalosporins is up to 30% or less, or even less. So it is not quite often. So if the patient did not have anaphylactic reaction, the serious reaction to penicillin, usually you can proceed with penicillins too. But if there was anaphylaxis, then you can go to cephalosporins. And with carbapenems, With meropenem, we usually think that we are on the safe side because sometimes you don't have other choice besides beta-lactams. And there is no significant cross-reaction between natural penicillins and carbapenems.
Дуже дякую за відповідь.
Thank you very much for your answer.
Що ви думаєте з
The next
приводу
question is,
комбінації
what do you
меропенему
think
та
about
азитроміцину
combination
проти
of
схабнітої
meropenem
палички?
and
І уточнюється, чи
azithromycin
це
against
комбінація
pseudomonas
проти формування біоплівки? Чи чули ви
and
про таке? Що ви
the
про це
combination
думаєте?
against biofilm formation? Have you heard about this?
I have to say that azithromycin is a Croatian drug. It was invented here in Zagreb. I don't know if you know this, but in Croatia, it is very misused. Okay, and this potential effects of azithromycin, which are not those antimicrobial ones, like anti-inflammatory effect, like antibiofilm effect. Actually, no one proved this. Okay, there are always some ideas of adding azithromycin to beta-lactams in forms of some kind of even immunomodulation in severe pneumonia. Actually, we are combining these two drugs in severe pneumonia because we are afraid of some atypical bacterial pathogens like Legionella in severe pneumonia. But actually, it was not proven that azithromycin has a positive effect on biofilm formation or on anti-inflammatory. Especially, it was very misused in Croatia during the COVID times because of this potential anti-inflammatory effect. But maybe someone will prove something in the future, but at this moment, we don't have enough evidence to give azithromycin for this indication.
Дуже дякую за відповідь. Я розумію,
Thank you very much.
звідки воно росте, тому що
I understand the origin of it because
поширена ідея, що треба комбінувати
we have
з
some
тим же самим
prevalent
азитроміцином
idea
для боротьби з біоплівками.
that it
Є
should be
певні
combined
поодинокі дослідження, але я, як
to find
сторонник доказової
biofilm.
медицини,
There are some
наголошую, що ми
single
маємо
studies, but I,
опиратися в галузеві
as a
стандарти,
supporter of the evidence-based
відштовхуватися
medicine,
від
I want to
мета-аналізів та
emphasize that we should be
високоякісних
based on
систематичних аналізів,
meta-analysis
а не
and
поодинокі дослідження. Тому
high-quality
я повністю
systematic
підтримую.
reviews.
Доки
That's
це
why I
кінцево
fully
не
support
доведено, широко це використовувати,
your
це знову ж
point.
таки ризики для пацієнтів.
Until it is proven,
Далі
it's quite
наступне
a risk
питання дуже
to be used
цікаве,
for the
і я
patients.
проговорю
Now, the
контекст.
next question is quite
Запитують, чи
interesting. I'll speak
використовуєте
about
у
the
вас в
context. The question
Хорватії
is, do
комбінований
you
засіб
use in
цефаліразон з
Croatia
сульбактамом,
the
і в яких
combination
випадках? Я це
of
проговорю в контексті того,
cefoperazone and
що
sulbactam?
він не є
And the
рекомендований до
context is the
комбінації
following.
БРІКС, і у нас часто
It's
задаються
not
питання про
recommended by
практичне
the
використання
WHO. And quite
цефаліразону з
often we
сульбактамом.
have many questions about using this combination. So do you use this combination in Croatia?
Ceftolozane tazobactam?
Цефопіразон з сульбактамом.
Cefoperazone
No.
and sulbactam.
No, we don't use cefoperazone, I would say, at all these days. It was associated with the severe side effects. So I would say that in Croatia it is we don't. I haven't not seen this for more than 15 years use of cefoperazone.
Дуже дякую за відповідь. Це насправді дуже
Thank
корисно.
you very much. Your answer is very useful, and it's really useful for our colleagues to understand why it is not recommended to be used in your country.
It was associated with serious side effects, with problems with coagulation. So we don't use it anymore.
Наступне питання, можливо, воно дещо вже такого ширшого бактеріологічного
The next question is about broader bacteriological spectrum. It's about the experience of interpretation in bacteriological studies. The organism was susceptible to amoxicillin, but it was not quite susceptible to amoxicillin and clavulanic acid. And the question is whether it is really possible, or maybe it was some mistake in the laboratory study.
I would say it was a mistake. Okay, I would not expect for the microorganism which is susceptible to amoxicillin not to be susceptible to amoxicillin clavulanic acid. But actually, I would say in this it could be a mistake. So it is question of the good lab practice. But concerning me as physician, for me it would not be a problem, because if I have amoxicillin susceptible pathogen and it is suitable drug, so it will come to the point of infection, and then I would opt for amoxicillin. Okay.
Дуже дякую за відповідь. Я розумію, що ми
Thanks
вже
a
трохи
lot for your
вичерпали
answer.
програму,
I think
тому
we're a
останнє
little bit
запитання, і ми будемо завершувати
beyond
нашу
the
сьогоднішню
schedule.
цікаву
So the
таку
last
плідну
question,
сесію.
and we will
Запитують,
complete
яке
today's very
відноситеся
interesting
до
session. The
комбінації
question is,
цефтазидиму
what is
з
your attitude to the
ампіциліном
combination
для
of
емпіричного лікування
ceftazidime
інфекцій
with
серцево-легеневих
ampicillin
шляхів
for
у дітях
empiric
до
treatment
6 місяців?
of UTIs in children under 6 months of age?
I would go for monotherapy. Okay, but I know what you mean, but I would go for if it is empirical therapy, then maybe there could be some point for this combination, but only if you are. But if you are dealing with the E. coli, which is susceptible, then you don't need ceftazidime. Okay, so but for empirical therapy, then I would go with the ceftazidime if I'm not suscepting group B streptococci.
Дякую за відповідь професора Сантіні.
Thank you for your answer, Professor Santini. Very interesting lecture, great answers. Thanks again for finding time and for joining our webinar. I would like to also mention that we had more than 200 listeners, and I'm sure even more people would want to see the recording. People are writing the words of gratitude in the chat. They're really grateful for your answers, for your webinar, and I would like to express my gratitude as well as my colleagues who are here, colleagues from the ICAP, Columbia University, colleagues from CDC, and other organizations involved in today's lecture and the future lectures. So colleagues, please subscribe to our Facebook page, to the page of the UPHC, to see the announcements, and we'll be happy to share interesting materials with you. So take care of yourselves, and everybody have a nice day.
Thank you. Thank you.